Okay, so thanks again for joining me. I appreciate it. We're just going to get started right away here. And so first off, what I always do is I always want to do my sound off. And so let me know where you all are watching from right now. Go ahead and put that in the comments while everyone's kind of filing in here. I'd love to see where everyone is from. So go ahead, throw that in the comments. Where are you all from? Hey, Willie, it's good to see you. Glad you're able to make it. Where are you all from? Go ahead, throw that in the comments. Louisiana, Florida, Arizona, Ohio, New York, Scotland. Love it. There you are. I was going to say, didn't load. Virginia, Vancouver, Roswell, New Mexico, Maysville, Kentucky, Oklahoma, Brooklyn, New York. Watching for the link from the email. Good. Saudi Arabia, awesome. Vancouver, Jacksonville, England, Durham, Pakistan, London, Georgia. This is all over the world. I love it. I love watching this. I think it's hilarious. Let's go look and see what TikTok's doing. Where are you guys on TikTok from? Let's see. Saudi Arabia, the Philippines, Pennsylvania, Wisconsin, Vegas, Arizona, Alberta, my stomping grounds. All right, on. Okay, so what we're going to be talking about today is managing a delirious, aggressive patient. These patients can be very challenging. However, they are a relatively common patient that we have to deal with. Psychological emergencies are a very, very common EMS-related call that we are going to have to deal with. They're difficult. Not every situation is the same. In fact, none of the situations are going to be the same. And so it's important to understand how to communicate appropriately with your partner and everyone else that's on this scene. So let's talk about how this is all going to work. So if you guys don't know who we are, or you're just kind of used to Master Medics, I'm Geoff. I'm the lead educator and the owner of Master Medics. What we do is that we teach EMS online from a totally different perspective. We are a very visual and very goal-oriented company where we want to make EMS education accessible and very visual and appealing to students and to practitioners, so that way we can enhance EMS education and make you better practitioners, make you better students. And so in doing that, we do have a school subscription and a student subscription that you guys can get on. You can get on for free, check it out for a few days, and if you love it, you can stay as long as you like. If you don't like it, you can cancel anytime, no problem at all. We have students all over the world that are using us. We've had tens of thousands of students come through us in order to use our sources, our exam preparations, our refreshers in order to get through school and get through their exams. We'd love to see you as part of that, and you can get the link in the bio. Will take you straight there. Other thing too is that if you love the way that we do education, you can do our education for your continuing education. We are CAPC accredited, we are accredited in Canada, we are accredited as well, and so you can use our case-based education for your continuing education credits. And so if you're interested in that, you can become a continuing education member as well, and that is also available at the link in our bios of our social media channels. Okay, so let's get that out of the way. Now let's talk about this case. You are dispatched to assist a police with an agitated patient at the subway. You find a patient that has open lacerations on both arms from shards of glass. Patient is clearly agitated and fighting with police and appears to be in a delirious state. Okay, so let's just play this video. Let's just pay attention here. This is what you see. You have a patient that obviously is in a completely delirious state, very aggressive state, fighting and not able to really focus. You can tell that he's in distress though. Like, this isn't a patient that's fighting to get away. This isn't a patient that's fighting to get away from police or anything like that. You can kind of tell by the way that he's moving around, the way that he's kind of holding his head. He's showing body language that's showing that he is in a paranoid, agitated state. He has a obviously something mental that's going on right now that's not allowing him to control his emotions and his actions. And so, and that's not to get him out of anything that he may do. This is more to just look at the body language and kind of understand the situation. And you can tell very quickly there's a difference between someone that is aggressively angry at that particular person, or they're having a difficult time mentally controlling the situation and are creating outbursts because of something that's going on in their own mind. And so that's kind of what this is looking like right now. This is what we would consider a delirious state, in which he's not able to control the emotional and physical impacts that he has. Okay, so that's kind of what we're dealing with at this particular point. Anyone that's been in paramedicine for long enough, I'm sure that they've dealt with a situation like this. Go ahead and throw that in the comments. If you're a paramedic or you're an EMT, let me know if you've been in this type of situation before, where you've had to assist police with this type of an aggressive, delirious behavior before. Go ahead, put that in the comments if you have been involved in a situation like this, where you've had to deal with these types of situations. Who's here been in this situation? Many times. Absolutely, hey? This is not an unusual situation. I think every paramedic, you may not see a true anaphylactic patient through, years of your career, but you will see dozens and dozens of these types of situations. These ones are very commonly ones that we get to attend and get to deal with. These are patients that can be very difficult to manage, which is why it's really important to manage them with other resources, other police officers, other paramedics that are there to kind of get the goal achieved, which is get this patient under control and get them to the hospital safely. Okay, so let's take a look at kind of deciding what we're dealing with here. And so we've kind of decided that this is an aggressive delirium state, or what's commonly known as excited delirium state. And so what are some signs and symptoms that you typically see that can confirm that this is an excited delirium state? Go ahead, put that in the comments. What are some signs and symptoms that we typically see in an excited delirium or agitated delirium state? What are some things? What do you think? Let's see what TikTok's thinking. Is it still called excited delirium? Not really. It's called agitated delirium now, but a lot of people still call it excited delirium, because you're right, they do change it a lot. Being very sweaty, diaphoretic, having delusions. What does that look like in a patient, though? Like, what does having delusions look like in a patient? Hyperactivity, they're overheated. Yeah, I agree, they definitely are. Hot, sweaty, breathless, hyperactive, paranoid, tachycardia, paranoia. Absolutely. Those are the kind of things that you're looking for. And you're absolutely, are they going to be tachycardic? Absolutely. And so those are the kind of things that you're looking for in order to confirm that this is an agitated delirium patient that needs to be addressed and needs to go to the hospital. And the reason that you need to identify this is because the likelihood of them going into arrest is higher, and it's usually due to their overheated and hyperactive state, that they're in tachycardia, they have a hyperheated state, and they often will have a complete shift and imbalance within their bodies as well, metabolically. And so their chances of going into arrest are higher. And when they go into arrest, it's very difficult to achieve ROSC with them for all of these metabolic reasons. And so that's why it's important to identify when you're dealing with an excited delirium or an agitated delirium state. And the things that you're looking for are bizarre, aggressive behavior, shouting, panic behavior, violence towards others, extreme physical strength, and hyperthermia. One thing you will notice in these types of patients that are in a true agitated delirium or excited delirium state is they're almost always with limited clothing. They might just have their underwear on. They might be completely naked. And the reason being is that they have a primal thought or a primal feeling that they are getting too hot, that they are feeling uncomfortable with clothes on because they are so hot. So they often are, and in this case as well, they often are quite pretty close to naked, if not completely naked, because of that feeling that they need to get this heat off them, or these entrapping clothes on them off. So those are the kind of things that you can expect in these types of situations. And the fact that they're sweaty doesn't help, because when you're trying to restrain someone, it makes it very difficult to actually hold them down, because unfortunately they become very sweaty and very difficult to manage. Okay. So why do they end up in this state? Okay, how is this any different than some other aggressive states? Well, or some sort of alcohol intoxications, anything like that. Well, the reason that it's different is because they have a completely different outlook on what's going on inside their body. Okay, so here's how an aggressive delirium occurs. So in normal functions within our bodies, you and I right now, if we're not on any medications that are inhibiting this action happening, dopamine enters into the synaptic cleft like so in order to attach to the postsynaptic neuron in order to create its reaction and create a dopaminergic reaction. And so after that occurs, after it creates that dopaminergic reaction, dopamine typically gets re-upped into the presynaptic cleft like so that way it can be recycled and reused for another neurotransmission. Okay. However, most patients that have excited delirium or agitated delirium, they are patients that already are on some sort of medication that has psychological impacts. And when it comes to psychological medications, most of them actually have this mechanism where it blocks dopamine reuptake. And so in order to create its psychological reaction, it's allowing dopamine to stay into the synapse itself longer. So it's staying in this area longer to create more of an effect. That's how dopamine typically, or dopamine medications typically work, is that it keeps dopamine here. Now, one of the big things that happens with aggressive and agitated delirium is that often these patients are using medications that are going to cause an effect. For example, cocaine and methamphetamines. And that's what is going to stimulate this agitated delirium, because things like cocaine and methamphetamines promote the release of more dopamine into the synapse. And if you're already on a medication that is stopping you from re-upping it, then you're going to end up with a significant amount of dopamine inside the synapse itself that's going to produce its effect at an alarming rate. And so we call this a dopamine dysfunction, or an inability to regulate dopamine. And when you can't do this, you end up with a very specific set of symptoms. Things like agitation and paranoia, violence towards others, extreme physical strength, hyperthermia, tachycardia, tachypnea, all the things that we have seen in this agitated delirium, excited delirium patient. Okay? And this is why they believe that this is why it's happening, is because of a dysregulation or irregulation of dopamine that's within the synapse that's creating these highly elevated dopamine levels that are creating these symptoms. And that's why the patients are the way that they are. Okay, so now that we understand the mechanism, or sorry, the pathophysiology of why we see these types of things, now my next question to you all is, what medications are we typically using right now in order to manage these patients? Go ahead, put that in the comments. What medications are we typically using to manage these patients now? What are we using? Droperidol? Yeah. It's a common medication to use in this situation, and we're going to explain why. What else? What else are we using? Is there a full video? Yeah, we have one in the Master Medics website, and so we'll be putting this in there. Then you can watch it from start to finish and get credits for it. We're learning about excited delirium. So what are some reasons? Okay, or what's some medications? Well, some of the medications that we're going to use typically in this state are going to be things like these. Haldol, or haloperidol, or droperidol. Okay, they'll both have the same mechanism. Midazolam, or Versed, is a second medication. Okay, and the third one is ketamine. Okay, these are the three medications that we typically use in order to control these states. So let's talk about let's talk about them separately and kind of the uses of them and some of the side effects that we got to be concerned about. So first off, midazolam, which is probably the most common, or any type of, or Ativan. Those are the type of medications that are within under benzodiazepines. They're the same medication mechanism, and so we're just using them in different states. And so we typically use midazolam or Versed, and typically the dose, and it's going to be often IM, because if you haven't dealt with these aggressive type of patients before, it's very challenging to get any type of line on them. So if you're expecting to get an IV on them, an IO on them, and holding them down long enough to make any of that occur, that's not going to happen. It's not a possibility in these situations. And so any medication that you're using, you're almost certainly doing it IM. Okay, so midazolam, 10 milligrams IM, Q 15 minutes, usually a max of 20 is pretty much as high of a max that you can go. And the biggest thing for using midazolam, as great as it is, it does have the significant effect of causing respiratory depression. And so in a patient that is being held down, okay, and you give them midazolam and you continue to put external force on that patient after they've been giving midazolam, the likelihood of positional asphyxia goes way up. So if you're using midazolam, be aware of its mechanism and understand that if you give it and you do not put the patient in a proper position, the likelihood of positional asphyxia goes straight up. Okay, so that's the first thing. Okay, that's midazolam for you. Does it have side effects? Absolutely. Is it usually a useful medication in this situation? Absolutely. Okay, second one, probably the second most common, if not almost the most common one now, is ketamine. Ketamine is 5 milligrams per kilogram. IM max 500 milligrams. Now, you're going to find different dosages throughout. I found this on a couple studies that have been using this dosages with success. However, the likelihood of intubation is fairly high when you're using high doses of ketamine, but I digress. That's typically the dose that you're seeing. Your protocols might vary, and again, follow your local protocol for this medication as well. So the biggest thing that you need to be aware of, especially in this hyperactive state, in a patient that has a tachycardia, has a lot of cocaine on board, they're going to metabolize medications very, very quickly. And the thing that you need to be worried about with ketamine is that when you metabolize ketamine very quickly, especially in high doses, you can cause apnea to occur at the very beginning of its, when you accumulate too much ketamine. And so there is a possibility of apnea that can occur because of a ketamine. So you need to be very aware of that. And you can also need to be concerned of the fact that they could have tachycardia. And so ketamine can induce more tachycardia, especially at higher doses. And then hyperthermia can also be precipitated with ketamine. So these are all more precautions than anything as far as why we shouldn't give ketamine. Ketamine is probably the most common. It's not my most common because it's not in my protocols as much for this type of patient. But as far as the common uses of ketamine, it's pretty high on the list. Okay, it's very commonly used with a lot of success. But any medication that you're using to control someone comes with risk, and these are some of the risks that you just need to be aware of. Okay. Next one is Haldol, 5 milligrams IM, Q 15 minutes, max of 10. You might find your protocol says 10 milligrams of Haldol. That's quite a bit. You really don't usually need that much, but I digress. 5 milligrams IM, Q 15 minutes, max 10. We're really undecided on what the doses are for these medications, so I pulled most of these from what my protocols are, just so I had a basis of it, but there's a lot of different varying protocols for giving these medications in these types of states. So the only thing you need to be worried about with Haldol or any type of psychotic medication is that these medications can prolong the QT interval. Now, typically we're seeing that concern is only at higher doses that we're seeing prolongation of QT. There was a recommendation on literally an article I wrote this morning. It says, yes, if you're using Haldol, always make sure that you get a 12-lead ECG prior to confirm the QT. Obviously, in this situation, he was literally talking about excited delirium and agitated delirium, and says, if you're going to give Haldol, make sure you get an ECG on this excited delirium patient. How realistic is that? It's not, right? So is there a concern of QT prolongation with Haldol? Yes. Is it at higher doses? Yes, it is. Okay, so typically the safety profile of Haldol is quite well received. I personally like using Haldol myself. Okay, so another thing that is actually probably the most common and something that's in my protocols for excited delirium or agitated delirium is using a combination of medications. In this particular case, in my particular case, it's using Haldol 5 milligrams together with midazolam at 10 milligrams IM. Both of them IM, 5 for Haldol, 10 for midaz, and that can achieve the effect that you're going for, where you get the sedative effect from midazolam, but you also get the dopamine blocking effect that you get from Haldol. That's kind of hitting the cause, right? Because we have a lot of influx of dopamine and dysregulation there. Psychotic medications typically affect the dopamine release, and so it's actually blocking one of the problems that we're having. And so this combination of drugs is pretty effective as well, compared to other options as well. Again, we really don't have the answer of what's best, but the two that are probably under the most agreement is either a use of ketamine at 5 milligrams per kilogram and use of this combination of polypharmacy of 5 of Haldol and 10 of Versed. Those are probably the most generally wide accepted options. Both of them come with their risks, both of them come with the benefits, and so those are the things that you have to weigh as a practitioner. Okay, so the way that this medication is going to be given IM, my advice is to keep in mind that you're going to be working with the police in this situation, law enforcement agencies. And so what you're going to deal with in this situation is that you want to make sure that everyone is on the right track, okay? And so you will have several police officers there with you, most likely. You'll have your partner, if not another ambulance as well, maybe even a BLS partner and providers as well with you. You should have several people. If you've been in these types of situations, you know it takes 5 to maybe even more people to actually physically restrain a patient that has having a true agitated delirium. So another thing that is going to be important is that you're going to drop your medications early, okay, and make sure that everyone on the team is aware that you have them, okay, so that way they know that if they do get a chance to restrain this patient, that they are looking for you to administer that medication. So draw it up early and make sure that you are identified with the law enforcement agencies, that you are the person with the medication, so they are aware to make sure that you are included in the restraining of this patient, okay? And that means that you're not going to get involved in the restraining yourself, meaning that you're not going to put hands on the patient until you're actually giving this medication. Because I've been in this situation where before, I drop the medications, I put them in my pocket ready to give, and then this patient gets into a physical altercation with the police, and then I'm getting hands on and trying to restrain the patient. All of a sudden says, okay, we got him restrained, let's give him the medication. And now I have to get hands off in order to grab my medications. Okay? If you end up in that situation, then what you need to do simply is just let everyone know that you need to get hands off to get the medication, so that way someone can take over your position. Okay? But typically, if you are able to, try and be hands off until you're giving that medication, so you don't end up in a situation where you have to come hands off in order to give it, so that way this patient doesn't have a chance in order to move and wiggle free from the restraining, because that's going to be very difficult for everyone involved if they lose grip of this person because they lost your weight on them. Okay, so another thing too is if this patient is going to end up being tasered, they're going to get a discharge. You actually want to give the medication typically while the discharge is occurring, if they are using electrical discharge weapons, because that can't transfer really into you as long as you don't touch the wires or the prongs themselves, and into a large muscle group away from the wires and away from the distance or the arcs. Reason being is because as soon as that electrical impulse has stopped, then that person's going to get up and start to be able to freely move again. Okay, usually it only affects them if it affects them while during that electrical discharge, and only at that time they pop back up right away. And so the idea is that when they get electrically discharged, they fall to the ground, restrain on, okay, and then you give the medication. Okay, that would be the idea with that situation. There's a lot of different situations, but the key to it is to communicate with your team to make sure that this gets done safely. Okay, so let's talk about after you've sedated this patient. So you've managed to sedate this patient, you've decided to use ketamine or fentanyl and Haldol, Versed and Haldol, whatever the case may be. Now you're transporting this patient to the hospital. So what are some considerations that you need to take on the way to the hospital with this particular patient? Go ahead, put those in the comments. What are some things that are of a concern to you on the way to the hospital? Let's say you got 20 minutes. Cautions, risk of respiratory depression, positional asphyxia, compartment syndrome, death, absolutely. Appropriate restraints, respiratory rate, position, I love it. O2, end tidal. Let's see here. What do you guys think? Enough meds on board to help them stay calm, respiratory ECG, waking up? Absolutely. I totally agree. Hey, lots of great thoughts. Okay, so here's mine that I put in here that I think that are really important to be thinking about. Also, let's just take note of how relaxed this guy is, as well as how old this stretcher is. I thought that was hilarious. I almost didn't pick this picture, and then I saw it, and I was like, I have to put this picture in here. So anyways, I digress. So first thing is that one of the biggest things that they're going to go into cardiac arrest and they're going to continue to deteriorate is their temperature, how hyperthermic they are. So we want to start to treat that. Fluid boluses, trying to cool this patient as rapidly as possible. If they still have clothes on, probably getting them off in order to, again, release some of that trapped heat. So actively cooling your patient is a really big benefit for these patients, so that way they don't get into that really extreme state that they can actually go into an arrest. That's the first thing. Second thing is position. So as soon as you have given this medication, as soon as you've actually chemically restrained them, make sure that they continue to be in restraints, but make sure that they are not in a prone position. Okay, this is still a thing that still happens and still gets people in trouble. So if your patient is in a sedated state, they should be restrained in a low Fowler's type of position, okay, not a prone position. I still have to teach that some reason. Okay, not a prone position. So they need to be in a low Fowler state, okay, much like this patient is now, not in prone state. Okay, final thing that I like to think about is EtCO2 and our SpO2. Okay, EtCO2 nasal cannula, throw that nasal cannula on 3 liters per minute, maintain oxygenation. Second thing is maintain a good waveform and making sure that they have a good breathing rate. Remember, if you're using things like if you're using things like Versed and Haldol, Versed particularly can cause respiratory depression. So if you're continually giving more redoses of Versed in order to maintain the sedative state, which you likely will need to do, then there's always a risk that this patient's going to have respiratory compromise and respiratory depression, maybe even apnea. And so it's really important to make in a conscious patient that you're not intubating is using end-tidal CO2 nasal cannulas in order to confirm that you still have a respiratory drive. And if it goes away, if they stop breathing, you're going to get an alarm immediately, so that way you know that you need to switch to an OPA and BVM if needed. Okay? So when you're transporting this patient, try and control the temperature. Make sure that they are in a low Fowler's, not prone position, and secure them in this position with soft restraints. And third, make sure you're monitoring the SpO2 and the end-tidal CO2 to confirm that they still have a respiratory drive despite the medications that you're using to redose them and keep them chemically restrained. And they go to the hospital. They do not go to jail. Okay, they'll go to the hospital, get treatment, get reassessed, and get further treatment. They're not out of the woods yet because they are calm. Okay, they still have a lot metabolically going on. I talked about these kind of as that third one is, so I'm just going to move through here. So, without further ado, do you have any questions about this patient and how to manage them appropriately? Go ahead, throw that in the comments. Any questions? Just going to check. I think we lost TikTok a little while ago. Oop. Any questions?